conference so far? Yeah. All right, very good. I know I've met a lot of you. My name's Adam. My daughter Harper is 8 years old and has Wilson syndrome, and just joined the board recently, and so we get a chance to introduce our speakers this morning. And for that, we're joined by Dr. Stephen Ryan and Dr. Adam Langenfeld. I'll introduce them both relatively quickly because they can say more about all this stuff that I'm about to say than I can for sure. But Dr. Ryan is a pediatric psychologist at Children's Minnesota in the Department of Neuro-developmental Services. He received his doctorate from the University of Iowa and completed an internship and postdoctoral fellowship at the Kennedy Krieger Institute, Johns Hopkins University School of Medicine. During training, he specialized in using ABA to assess and treat severe challenging behaviors in pediatric populations. His treatment focus has expanded to address other issues common to children diagnosed with neurodevelopmental conditions, such as sleep disruption, toileting difficulties, and he has extensive experience in neurodevelopmental assessment. Dr. Ryan enjoys spending time with his wife and 2 daughters. I have a wife and 2 daughters too, so I know how fun that can be. And spending time exercising outdoors. I do less of that. And cheering on the Iowa Hawkeyes. I do none of that. Dr. Langenfeld is a board-certified pediatrician, also at Children's Minnesota in the Department of Developmental and Behavioral Pediatrics. Completed his graduate medical degrees at the University of Illinois, Urbana-Champaign, and then completed his pediatric residency at Children's Hospital of Wisconsin in Milwaukee. He completed a subspecialty training in developmental and behavioral pediatrics at the University of Minnesota before starting with Children's Minnesota. His special interests include childhood development, working with children who have developmental delays, and working with families to promote health and well-being in their children. In his free time, he also spends time with his wife and children exploring parks, farmers markets, and restaurants. I do all of those things. Sounds a little bit more fun, if I'm being honest, and being physically active outdoors. So, doctors, take it away. Thank you.
Thank you. Can you guys hear me okay? Good, okay. All right, well, I'm going to start today, so thank you so much for inviting us to participate in this conference. We're really excited to be here, and we did talk a little bit about our clothing options, so we coordinated as much as we could, I suppose. Yeah, the Children's does not have a uniform. This is not like the standard pediatric uniform at Children's. So today, Dr. Ryan and I are going to be sort of splitting up into 2 different sections, talking about the dual role that we can play as a developmental behavioral pediatrician and as a pediatric psychologist in working with the assessment and treatment of children with neurodevelopmental disorders. And we'll do our best to try to have the talk be focused on children with Wilson, but also be speaking more broadly to the kinds of patients that we see. We do have some disclaimers just that come from children, so we won't spend too much time reading about that today. So today, we're going to be talking about a couple different things. In my section of the talk, we're going to be talking about developmental and behavioral pediatrics. It's not a field that everybody knows about. It's not a huge field of pediatrics, but it is one that is very, very important. So I'm going to talk a little bit about what it is, the history of it, things that we do, things that we can't do, limitations as well. I'm going to be talking about how we fit in with the whole multidisciplinary care team to partner with families in caring for children with complex medical, developmental, behavioral needs. And then I'm going to hand off to Dr. Ryan to talk about behavioral framework as a way of understanding challenging behaviors, and then talking about how we can use that framework to treat challenging behaviors and other struggles. So the sort of background or backbone of my talk is an article that was published in the journal Pediatrics, which is the main pediatrician journal in the United States, that was written by a group of developmental pediatricians to talk about defining developmental and behavioral pediatrics. I'll read to you the definition here. It's kind of long, but developmental and behavioral pediatrics is a board-certified medical subspecialty that cares for children with complex and severe DBP problems by recognizing the multifaceted influences on the development and behavior of children and addressing them through systems-based practice and a neurodevelopmental strengths-based approach that optimizes functioning. That's a lot of words, but I want to just highlight a couple of things. So as Adam mentioned when he introduced us, it's a board-certified medical subspecialty. So it involves studying a lot and certifying with a medical board that make sure that you are up to date on your education and make sure that you are following the best practice guidelines for care of your patients. It cares for children with complex and severe DBP problems. So we do see children who have a lot of complexity, kind of, if you think about your general pediatrician who you see in the clinic for your well child visits, we do a little bit more related to these complex issues. Recognizing the multifaceted influence on development and behavior of children. So understanding that there's a lot that goes into a child's growth and development and how that impacts their overall health. And addressing them through a systems-based practice and a neurodevelopmental strengths-based approach that optimizes functioning. So we're really looking at how the child fits within a larger picture, not just the child individually or the illness individually per se, but how it all kind of fits together. And we really look for identifying and optimizing strengths. So not just looking at, okay, here's a problem, but looking at what are the things that are really good about this person and what are the ways that we can help to enhance that. So there's a couple of different models that we base this on. One of these is it's called the biopsychosocial model of development. This is an image that I did find online, colorful for Pride Month this month if you do celebrate that. But really looking at how different aspects of both biological, psychological, and social pieces interact together. So for example, the biological, we're talking about physical health. We're talking about if there's a genetic disorder like Mowat-Wilson syndrome, or if there are other disabilities that the child may have. The health and sort of how they respond to illnesses, like some people are more susceptible to different illnesses. So this is the core of the medical part of the training that we have. We talk about the social or environmental, so how the family circumstances, how the family dynamic works together, how maybe cultural traditions or interactions play a role in deciding what kind of care a patient or a person might receive. Different social supports, like are you located in a place where you may or may not have family nearby? Education of the child, but also the parents and the extended family members. And then the psychological piece, and this has to do with behaviors, the personality of the child and the family members, different skills that they may have, coping skills or emotional skills, social skills, like how these have developed and played a role in how they interact with the world around them. And when we put all these together, there are these, in this Venn diagram, there are overlaps. So for example, if we overlap psychological and social, we might see effects on family relationships or different big life events that could impact how the family or the person and the family interact with each other. With biological and social, we could see, for medication use, we do in my practice, we use a lot of different medications, but seeing how these medications or other substances might affect the person, and then overlapping biological and social or psychological, how, does the temperament of the child or the person develop. So when we put all of these together, we're looking at mental health, and that's really, a big part of what we help with when we practice. One other way to think about this is called an ecological systems model, and this image, I will admit, is very, very busy, and can be a little bit hard to dive into. But this is an image of what we call a ecological systems model that was developed by a philosopher actually named Bronfenbrenner, who was looking at how an individual fits within different layers, different systems around them. So in this case, what we're looking at is the individual in the center, and then outside of them there are different systems. So a microsystem might involve their parents, might involve the school, the healthcare providers that are around them, teachers, if they're old enough and involved with social media, things like that. So how they sort of interact with the direct space around them. But then beyond that, how they interact with, a bigger system, like the exosystem, where it's, the school system, not just the school they go to, but like the, school district that they're in, what kinds of resources are available to them in that space. Looking at, it's a little bit small here, but looking at sort of the environment around them. Do they have access to outdoor spaces? Do they have access to services that might not be available in some cases? What is their parents' employer like? What is the media around them like? So really looking at how they fit in. And for this image in particular, this one was geared more towards children who are of different racial backgrounds, and seeing how, how do we interact with things like systemic racism, cultural interactions, and things of that nature. So again, understanding that the child by themselves is one piece of a larger system and how they interact with each other. So really, when we're looking at how we interact with our families, this is one of the ways that we really think about how everything kind of fits together. So to step back and talk about developmental behavioral pediatrics a little bit more, really what the field kind of evolved from was a shift in the mindset around treatment. And it was shifting from treating acute diseases to incorporating management of chronic diseases, disabilities, and behavioral and emotional concerns. So really thinking less about solving a problem right now and thinking more about how do we help a child navigate the world around them. There was a section on child development through the American Academy of Pediatrics that was established in 1960, and this actually transitioned to what's called the section on developmental and behavioral pediatrics in the late 1980s. So we've currently, that section through the American Academy of Pediatrics is still active, and I'm a member now. There have been fellowships or extended training beyond your standard medical training that have been around since the 1950s, but it really was more recently that this became a standard fellowship training. One other piece of the puzzle that was very important was something called the University Centers for Excellence in Developmental Disabilities, or UCED. This is a group of different universities throughout the United States that are really focused on providing support and training and advocacy for people with developmental disabilities. And the University of Minnesota is a member of this program as well. This was established in the 60s, and it paved the way for a training program called the Leadership Education in Neuro-developmental Disabilities, or LEND program. And this program, again, very active throughout the United States. The University of Minnesota does have a group as well where they will have members from different disciplines who come together and really develop a sense of how all of these different people from different backgrounds interact and help people with disabilities. For my specialty, again, it became an accredited subspecialty with the American Board of Pediatrics in 2000. So we're really kind of, among the pediatric specialties, we're kind of a baby. Well, I guess now we're kind of in our mid-20s, but it is something that is now something that is board certified and is regulated by the ABP. So our training involves 4 years of medical school, 3 years of residency, passing of the general pediatric certification exam, which lets you be board certified in practicing general peds. So your pediatrician that you see for your well visits has done this. Additional 3 years of subspecialty training or fellowship in developmental pediatrics, passing a subspecialty certification exam. All that happens. I also did a doctorate, so I was in training until it took a long time. But as they say in the article, we are medical subspecialists, so we do a lot of that training. We also do additional training in, again, the LEND program, or the Leadership Education in Neurodevelopmental Disabilities. I did a training in leadership education in adolescent health, so again, working with adolescents to really focus on their growth and development. We're involved in interdisciplinary team evaluation, so working with people like Dr. Ryan, working with different rehabilitation therapists. I think we had our occupational and physical therapist with us yesterday. Doing scholarly activity, including research and education of different trainees, and then working on advocacy training and opportunities. So the best example I have is back during my training, I did get a chance to go to Washington, D.C. and lobby with my Congress people for supports for people with developmental disabilities. So the roles that we have, evaluation and diagnosis, as Dr. Ryan and I are both discussing today, is a big part of what we do. We act in a consultation role as well. So if a primary care doctor or a subspecialist has some questions about behaviors or developmental progress, we can come in and play a consultative role. We do a lot of interdisciplinary work with different subspecialties, including working with others for educational purposes. So we're helping others kind of understand what we do and understand how we can fit in the bigger team. We do a lot of therapeutic counseling and coaching, and then also treatment for different things that we're working with, and we'll talk a little bit about that. This is a list from that article about the types of things that we see, and it's, again, big long list. I'm going to highlight a few here that might be more relevant. Anxiety and depression symptoms. So for people who are maybe experiencing more anxiety or having some mental health issues, we definitely help with that. Intellectual disability and learning issues is something we definitely will work with for patients and families. Speech and language disorders. We see a lot of children who have differences in how they communicate. Developmental delays more broadly, certainly, and then also medically complex patients who have DPP issues. So we don't see every medically complex patient, but we do see a lot of them who do have additional concerns that could be that we could potentially help with. And again, this is a very long list, so if you do have a chance to find that article, which I do believe is available for free online, you can see all the kinds of things that we do. Given all that, there are some limitations. First of all, there's a very small number of providers. In the United States right now, I think there's somewhere in the range of 750 board-certified developmental pediatricians for the entire country. Not a lot of opportunities to learn about our field. So our medical residents get about a month of contact with us, but that's about it. And then if you're in medical school, you may or may not actually learn about what we do at all. Because we are a field that does a lot of talking and not a lot of procedures, we don't get reimbursed very well. We have a lot of patients in our system who are on Medicaid, so it can be difficult to get reimbursement for our services. And then because there are not that many of us and we're located kind of in a certain space, especially Minnesota, you can have long wait times and driving distances to find us. I pulled this data from the American Board of Pediatrics website. Currently in Minnesota, there are 12 of us total for the entire state. And per clinician, it's about 100. It's one per about 109,000 children. So there's really not that many. So again, 12 and 109,000. So, and you can see here in this map, nearly everybody is located in the Twin Cities. This is Mayo Clinic, where there are a couple of providers, and this is up kind of towards Duluth. But that's pretty much it. So if you go, the next closest people available, I believe, are in Sanford in South Dakota. And then down in Iowa as well. I think there may be some in Wisconsin, but where I trained in Milwaukee, there were no developmental pediatricians.
So this site that you got that from, you can search your state?
Yes. Yep. So this is, yeah, I chose Minnesota because that's where we are, but yeah, you can do the state. One of my colleagues in the clinic was saying she has a family that's moving to Oklahoma, and they're looking for developmental pediatrics care, and I believe when she looked, there was just one for the whole state. So there's really not that many of us. This is another set of data from the American Academy of Pediatrics looking at how far does someone need to drive to obtain subspecialty care. And I'll just highlight it for you. We're third as far as the longest drive that someone may have. So in this case, the average driving distance is around 40 miles, but some people may have to drive over 300 miles to see us. Luckily, telehealth has helped that a lot, is the good news. So we have less of an issue with that now than we used to, but I definitely see families who are way up north in like the Iron Range and things like that. How we're involved, we will help with supporting developmental assessments, so helping with clinical and school-based assessments for children who are old enough to go to school, IEP evaluations or 504 evaluations. We do help with supporting diagnostic assessments, helping getting our patients to people like Dr. Ryan for doing their cognitive and adaptive testing. We can help talk about therapeutic and community resources. In Minnesota, we have early intervention through the Help Me Grow program. So we help get connected with that and make referrals. We do have issues that we will work on specifically, feeding issues, behavioral issues, parent-child relationship challenges if those are happening. And then for specific conditions, we can talk about evaluation, diagnosis, and treatment of those. We can, again, act in a consultative role or work with families long-term. I love having families that I get to see long-term. I've had some of them even through training now. I've been in this field for about 5 years, and I've had some since I've started training who are still with me, which I'm really happy about. Again, coaching, medication management, and then really trying to work with and collaborate with other specialties. We used evidence-based interventions in our practice, so we make sure that we follow the latest guidelines like any good medical provider would. With our counseling and coaching, we can do family meetings. I've had an interest in the past in mindfulness meditation, primarily for parents, but also for children. Some of the people in my field are very interested and work with medical hypnosis as well. So for children who might have a lot of anxiety or might have a lot of concerns with going to, say, a hospital visit or things like that. And then, again, other anxiety management strategies. As a medical provider, I do work with medication management as well. So we'll always discuss what options are available, discuss benefits, side effects, and then we work closely with families to make sure that if we are using something that we're paying close attention and seeing how they're responding to that. I was thinking a little bit about how someone like me could play a role in the children that you have, the families that you all work with. In looking at the information that we have, and I will admit, I do not have any children currently in my practice who have Mowat-Wilson syndrome. I have not seen it personally yet, but what I can see, we do see that there's intellectual disability that comes out. Language development can be impacted. So one way that we can help connect is if we do, play a role in your care, is to help get connected with the services that you might need. So seeing someone like Dr. Ryan for an evaluation, some therapeutic management, trying to get connected with rehabilitation therapies, speech therapy, occupational physical therapies, to address those developmental challenges, address those sensory processing differences. Working with constipation management, like we do prescribe medicines for constipation pretty regularly. Working on medication management for sleep, or including overnight awakenings, early morning awakenings if that's an issue. For co-occurring mental health concerns, working with, for example, anxiety management from a medication standpoint. Those are things that we can do, definitely. So, the main thing that I just want you to take away, if you remember anything from today, is that, if you have the opportunity to work with someone who's in developmental behavioral pediatrics, what you're looking at is someone who's a medical subspecialist who works with children who have complex issues, problems, by recognizing the multifaceted influences on their development and behavior, and recognizing that we're part of a team. We work with interdisciplinary groups to support children with complex developmental and behavioral issues by providing resources, by providing counseling, providing medication management. So with that, I'm going to pass over to Dr. Ryan. We're going to collaborate on different ways that we can work on managing behaviors.
Everyone hear me? We're good? Yep. Awesome. Well, thank you, Dr. Langenfeld, for queuing everything up there. Don't want to comment too much on our matching, but we could go on the road after this, I guess, and put these on everywhere, right? This isn't mentioned up here, but I think one of the things that Dr. Langenfeld mentioned, which I think is really powerful, is that when we think about how these complex kiddos fit into complex care models, the way I kind of view this is that it kind of acts like a bridge that is not one way, but rather two-way, right? That can exchange across different specialties as we integrate and lock together in order to provide this net of care around these medically complex kids. And so, for example, somebody might present to Dr. Langenfeld's clinic with X number of concerns due to genetic or developmental differences. And then he identifies, boy, what we really need, or what the roadblocks are going to be here are, we need an assessment to see kind of strengths and weaknesses here. Or, as we live in sort of this gatekeeper society, we need to get you to the right person who can assign the right diagnoses and whatnot to get you access and remove the roadblocks to get to this place. And so then Dr. Langenfeld might send him on over to me, and I might do some assessment, or we might work on some things treatment-wise. And then during that process, we might say, boy, we're having some issues here, here, and here. Dr. Langenfeld needs some help here, right? So then I might send him back or send him a message and say, all right, why don't you go back to here? And he's like, okay, let's send out these referrals. So, I mean, it goes on, and it's kind of this complex web, and I think that you guys, in this space probably have a lot of experience with that. And so one of the things that I view Dr. Langenfeld's field as he's kind of the central node that can help get all of these families to all these wonderful services that they so greatly need. So anyway, just wanted to throw that out there. Just a little bit about myself. I completed my bachelor's and then doctorate at the University of Iowa. As the other Adam also already brought up, big fan of the Iowa Hawkeyes there, so for all who celebrate, go Hawks. Then after that, I completed my internship and fellowship out in Baltimore, Maryland there at Kennedy Krieger, which is affiliated with Johns Hopkins School of Medicine. That particular institution there is as I've gotten more and more experience with other folks with different training backgrounds. It's kind of like a little bit of a playground. If anybody y'all know that or are from the East Coast there, it's kind of a hub for working with kiddos who have these types of developmental challenges. And so the things that are possible there, I kind of talk with other people about, things that are possible there are not possible in a whole lot of other places. And so that really kind of gave me a pretty cool experience in terms of the intensity of service that we can provide these complex kids. So during my time there, I emphasized or specialized in treating kids who have complex developmental needs who also have really severe challenging behaviors. And those challenging behaviors might range from aggressive behavior, disruptive behavior, self-injurious behavior, things like that. Common diagnoses we may have seen was a whole host of genetic conditions, but also autism, things like that. I had the wonderful opportunity while I was there to get interactions with families who sort of in a similar boat. They may have a child with an incredibly rare condition. Because of the unique seat of Johns Hopkins there, they are able to have specialists there who may they may be one of a handful or one of one specialists in the world who deal with certain conditions, and so that was kind of a nice opportunity there to see a number of things that I probably would not have seen otherwise just due to the prevalence of those conditions, right? So as we look at kind of these behaviors, that's kind of, like I said, sort of this area of expertise that I've developed, and certainly not all kids who have certain developmental conditions have these types of behaviors. Those are oftentimes the kiddos or the families that I see, because obviously these things are really stressful to parents. And so as they're stressful to parents and families, then, assuming we're in a place where we can have access to routing to specialists that can do this, that's where, kind of I come in here. So looking at sort of some general statistics here, I mean, like I said, not every kid who has a developmental issue has challenging behavior, but certainly a subset of the population does. There we go. 5 to 14% is kind of the estimate here. And then specializing this down into Mowat-Wilson here. One study, it's a little dated now, I think it's 10 or 12 years old at this point, had estimated that over 30% of individuals with this specific syndrome have challenges with emotional and behavioral regulation here. So obviously that is very stressful to families, but also we've shown the connections there between those challenging behaviors and then other indicators of negative outcome, right? So that can result in poor academic performance, higher risk of physical injury, both to the child, but then also any parent who's trying to manage that behavior. And then oftentimes what we know is that if we do not address these things, the likelihood that they're just going to spontaneously get better is relatively low. So making sure that we're intervening on things when they're more manageable so that we can prevent them from persisting into adolescence or adulthood. One of the things that I like to talk with parents about is kind of stressing the urgency of addressing and looking at some of these things, because I think that we get so caught up, and rightfully so, on the importance of early intervention and things like that. But the trick there is that it doesn't stop there, right? And so our young kiddos who have developmental disabilities or challenging behaviors grow into adolescents who have those, grow into adults who have those, which are much more difficult to manage during that time, right? So one of the things I tell parents is, kind of the way this is going, or the trajectory this is going, is just not in our favor. All of our kids are getting older and bigger and stronger, and we're all getting older and weaker. So we kind of work on this before we get to that point where we're going to have a lot of challenge there, right? Also, and we'll get into this in a little bit, the more entrenched these patterns of behavior become, the more resistant they are to change, right? And I think we all see that even in our everyday life, where if we have a habit that has been occurring for years and years, it is harder to break that habit than one we just started last week, right? So I was also, even though I've seen a number of incredibly rare genetic things, this is not one that's been on my list yet. So in preparing to talk with y'all, I had to do a lot of research on kind of bringing myself up to speed on what this means exactly for your certain kiddos here. So I don't know if you guys have seen this study. We talk about, of course, there's the genetic backdrop. So what are the specific gene mutations or things like that we identify, and then we name these things. That's called the genotype. But how does this thing get expressed in an individual? And specifically, what is the behavioral phenotype, which is what we call it, of this specific syndrome? And so more and more work is being done to identify, what are the commonly presenting or occurring things that we see with certain things, right? So trying to get understanding, we can take a big sample of, let's just say, kids with Down syndrome. We understand that, hey, these are very common issues that we see behaviorally with those types of kiddos. And the same is true, that work is being done with many other types of syndromes, Mowat-Wilson being one of them, right? So this is a study that relatively small, but essentially surveying and giving a behavioral rating form to, I believe, is about 60 children diagnosed with MWS, and then comparing how that looked in relation to a sample of about 120 kids who just had intellectual disability from other causes, okay? And essentially what they found is that the most commonly reported issues in relation to their comparison group of other kids just with more straightforward intellectual disability is that these kiddos tended to have more oral or mouthing type behaviors, more repetitive behaviors, things like that. In addition, this also found that in that subset of kids, about 30, over 30% of them had or were rated as having significant emotional and behavioral challenges, right? So it kind of, while obviously no one child is the same, kind of sets the stage in terms of what we're looking for or things that we could be preparing for to try and understand and then maybe think about how we're going to come up with treatment strategies for that. So how do we work through this? That is the challenge. So I already kind of talked about how all of these kids are so different, and the more I practice, the more I just kind of continue to create files in my drawer, so to speak, of different presentations and all the fun things that kids do. It's kind of tongue-in-cheek. A lot of them aren't fun, or at least the ones that I see. But the way I understand these things is kind of important to how successful we are with understanding and treating those behaviors, okay? And so most of my training was within this field of applied behavior analysis, or ABA, and that is really kind of a framework to understand how these behaviors essentially interact for the kids and their environment, right? So within this field, this treatment approach is oftentimes applied with many kids of all different types of developmental backdrops. The uniting factor is that a lot of it is done with kiddos with developmental disabilities. Along with that, for many of those children, they also have difficulties with communication. So the way that within this ABA, one way to conceptualize or how we view some of these behaviors that we see is that oftentimes these serve as communication, right? So if we don't have the luxury of being able to say, I think I'm tired of this, I would like a break, oftentimes we see behaviors come out which are designed, to accomplish that, right? But essentially, it is without that lack of communication, we are then using that behavior to push that forward. So essentially, because a lot of these kiddos have difficulties with communication, then it is harder for us to get a straight answer when trying to figure out what's going on, what's wrong, how can I help you, what is it about this situation that is not okay, right? So rather than trying to sit there and really kind of rack our brains about what do we think is going on inside that head, we tend to focus more on what are the observable behaviors that we can see so that we can understand by observing what is it that is going on here and why do these things basically occur predictably, all right? So essentially, this perspective is used as a framework to understand, and this is kind of, again, a kind of a mouthful, the environmental contingencies that shape our behavior, right? The good news is that we know that these things are present for all of us. It's not just for kids, it's not for adolescents, it's not for kiddos with developmental disabilities. Behavioral contingencies shape everything, okay? And that is true for us in our everyday lives, right? I mean, so, if someone were to say, hey, Dr. Ryan, Dr. Langenfeld, if you guys show up in matching outfits, we will give you $1,000, okay? Not even close, right? How would that affect the decisions that we make on what we wear? Now, full disclosure, we were paid nothing to wear matching outfits, right? But that affects our decisions on what we do, right? So the same is true for our kiddos, except their motivations usually tend to be a little bit more linear, a little bit more simplistic, okay? So we already kind of talked about this, right? But behaviors that are reinforced are likely to be repeated, right? So things that result in good for us, we tend to repeat. If we do things at work that result in a promotion, we're going to keep going back to that well. Do things that result in us getting in trouble, we're going to shy away from that stuff, right? So once we identify what things are reinforcing, then we can assign a function to that behavior. And we're going to go through some things here. I do want to make sure that I'm mindful on time here so that we're not running over and we don't have time for questions and all that, so I'm just going to keep that there. So when we think about what are the common things that are oftentimes assigned or the goals for these behaviors, right? We talk about these social functions here, okay? So the three most common, there's a study done, and that's quite a while ago now, looking at what are the commonly seen or observed reasons for these behaviors, right? Three main buckets emerged, all right? It does get more complex, but for the purposes of this is kind of how we'll talk through it. So first one is access to attention. So we have an issue here, we want attention, the behavior comes out. Access to tangible things, okay? So meaning like, I want this toy, want this food, etc. Behavior comes out. Escape from non-preferred situations. No, I don't want to brush my teeth. no, I don't want to get dressed, behavior comes out, okay? So designed to escape from those non-preferred situations. Another piece here, we call this a non-social function of the automatic or sensory as we think about how this stuff filters into Mowat-Wilson, right? So thinking about a lot of these oral, sensory, seeking behaviors, things that are designed like repetitive movements, these are almost always done for some sort of internal reason as opposed to something environmental that could be driving that behavior, okay? So again, we see that stuff all the time in things that we do, right? If I sit down and I'm there long enough, I might start bobbing my foot. Why would I be doing that? There's no environmental reason to do it, but some sort of internal motivation is driving that, and therefore I continue to do it. There's also reasons that we call more like idiosyncratic functions, and this is where you get into the nitty-gritty around like my specific kid does this weird thing, why is it happening? Okay? I don't know why it's happening, but we're going to have to probably figure that out, do some things to try and understand that, because if we don't understand it, then we're not going to be very successful in how we intervene on it. So this is the framework that we typically use to understand these behaviors, and it sort of lines things up in a very clean, linear way. And so oftentimes when we're talking, or I'm getting to know a family, I talk about these things in terms of, okay, if we want to understand these behaviors, we need to understand what triggers it, so this setting event, okay, so that we can know whether it's reliably happening in a predictable way. We need to know what are the behaviors that come out or are assigned with this trigger, and then we need to know what are they getting out of it that makes them either more likely or less likely to be able, to want to do this in the future. So these are common questions that I ask, or that I ask parents to ask themselves. Okay, so when does that behavior occur? Okay, that's the setting event. What happens right before the behavior? What triggers that behavior? If I wanted to see the behavior right now, what would I have to do to see it? Right? This is all trying to get a handle on, trying to understand all those different things that go into why behaviors occur. Okay? Then, how do you respond to that behavior? And this is usually the part that is said as least judgmentally as possible, because we all know when we're in those situations, it's survival, right? It's not necessarily like, oh, I'm just thinking about going through this really neat plan, right? It's more like, how do I manage this in a mall? How do I manage this at the store? How do I manage this at my kid's graduation party? Whatever it is, right? So how effective are you at stopping the behavior? What are the strategies that you use to do that? Are there things that you do that prevent, or in order to try and prevent that behavior? Are there things that you avoid doing because you know it will result in the behavior? All of these questions are designed to flesh out that relationship there, okay? So I'll take you through some examples here to try and illustrate this. All right, so we already talked about attention, or caregiver attention is one of those things that oftentimes drives these behaviors. So let's just say, for example, a child engages in a behavior to gain access to attention from others, right? So we might see, a parent is playing with a sibling or talking with a spouse, whatever. Child screams, hits the sibling, whatever that behavior is that comes out. And how do we respond? Oftentimes saying, safe hands, we don't do that, etc. And now we have this sequence that unfolds. One thing that I think is particularly hard to kind of wrap your mind around, and it took me a while too, is that this right here, even though it is a negative, a reprimand, a scold, whatever you want to call it, oftentimes attention is attention no matter what, and some kids actually prefer negative forms of attention over positive forms of attention. So a knock it off, don't do that, is more powerful to them than a hug and a high five. It's odd, but it's the way it works sometimes for some people. So what do we commonly see in terms of like how these things are triggered and consequences? Well, parent is attending to someone else, a sibling, a spouse. Parent is busy, on the phone, doing work. It's very common for me to hear things like, everything was sailing, everything was smooth, and then my husband or wife called me and about what they needed at the grocery store, and now my kid is going bonkers, and I don't understand how that emerged, right? Or this is a situation that happened, and now all of a sudden, out of nowhere, I wasn't able to figure out why they were. Well, oftentimes, if they detect that they do not have that attention that they would like, then we can see some of those behaviors go out, right? And that kind of ties into this last point here, right? Oftentimes, I hear, it was out of nowhere. Some of my experience suggests that sometimes, in the spirit of watching the world burn, sometimes when a kid is bored, they find ways to get some of that stimulation. They find ways to interact, and some of it is less than positive sometimes. So what do? How do we oftentimes respond to that? Well, reprimands, maybe we try and help them, soothe the child. We had a long talk about it, we talked through what's going on. Other people, like siblings, might laugh or have big reactions, and all of this can kind of play in with that attention there. Think about how this works in terms of like tangible reinforcement and things like that. Child, engages in behavior to gain access to those preferred things that they really want in their environment. So again, sibling has a preferred toy, the child screams, hit their sibling drops the toy, runs away, and along with the hurt feelings, our child who is engaging in those behaviors has now accomplished what they wanted to, which is getting that toy back, right? So, as we said, kind of common triggers for this, where kids want something, they're told no, preferred item is taken away, or we're saying, that's it, we've exhausted our limit for the iPad today, we're not going to have that anymore. The sibling takes a toy, child's asked to share, things like that. This is kind of how we see those behaviors come out. And then oftentimes, in terms of how we respond to that, parents can give in, they allow them to have what they want. We have a debate that ensues, or just like resistance that ends up delaying the removal of the item or the transition, or we start offering other things as a means to distract, or try and get them to relent because they're getting something else, okay? So again, going through this same sequence for escape, this is kind of why I like to go through this framework, because I feel like it gets sort of repetitive in a way that, like, once we understand the general sequence, we can apply it to a lot of different situations here. So, child is told to clean up, child screams and then hits the sibling, and then the child is sent to timeout. Timeout is one of those things, right, that, I don't know, probably since we were living in caves, parents were using timeout, right? However, depending on how it's used and when it's used, that could either be a good idea or a bad idea. So think about common things that trigger this. Child is told to clean up or put away toys. School difficulties, so like it's time to do some of your academic work or skill work. They might shut down and run away when asked to do something difficult, and if they're kind of showing some of these anxious behaviors or refusal, that can certainly set some of this off. And then again, common consequences might include going to timeout, parent helps them complete the task, or they remove the demand completely. So, we talked about some of these other things earlier. The way I kind of set this up is very sort of in like an individual function by function way, but oftentimes it can be more complicated than that. That would be an ideal situation where things are very clear to understand and we don't have to do too much work on trying to figure these things out. My experience is, oftentimes those look great in textbooks, but when we're out in practice, we see a lot more complex picture as to why these things could be happening. So we think about this sensory seeking stuff. So for example, the behavior itself is rewarding or occurs regardless of the environment. And it's kind of like, again, kind of thought about as like, it's like scratching an itch, right? So like you think about, for example, certain repetitive behaviors that kids do, whether that's hand flapping, whether that's rocking, whatever it is. There's no reason for them to be doing it that's apparent to us because there's no environmental, variable that seems to be turning it on or off. It just happens regardless of what they're doing or where they're at. And so oftentimes you see that with like sensory seeking behaviors or these other repetitive behaviors. And so, oftentimes we think about this in terms of what is this achieving for them, right? So it could be something positive like these sensations that they're getting, could be to take away other things, that are more aversive, right? So I remember working with an adolescent who we were kind of struggling to figure out why he was engaging in self-injury in sort of like the cyclical pattern. Couldn't quite figure it out, couldn't figure out anything in the environment, happening all over the place. And then we found out that this kid was suffering from migraines, okay? So all of a sudden, when we get a migraine, head-directed self-injury picks up. This is probably more Dr. Langenfeld's area of expertise, but any of y'all who are familiar with gate control theory, right? So like for pain, right, if we have pain in one area of the body, sometimes we can lessen that by when you have pain in another area of the body. So if a kid is suffering from migraines, sometimes they might increase self-injury in order to attenuate or reduce that feeling, right, of that aversive feeling that they're getting. Then, of course, things can't just be simple and straightforward. Sometimes it could be multiple things at one time, right? And so, for example, sometimes you can see one of my favorite, again, tongue-in-cheek or realistically least favorite situations is when I'm talking with a family who's talking about how things are going at school, and they tell me, well, the plan for when my kiddo gets dysregulated is we take the work away and then we take them to the sensory gym, okay? Well, it doesn't take a super savvy kid to realize that if I do these behaviors, then all of a sudden my work goes away and I get to go have fun and go do all this sensory stuff, right? And so that can become an issue. One of my least favorite to treat is this one here, the attention and escape. So this oftentimes comes out for kids who elope, right, or kids who run away. So I don't know if anyone here has experienced this, but the kid who is running away and smiling and laughing and looking back as they're running, right? So this is not only oftentimes triggered by things they don't want to do, so they get out of that situation, but then it triggers the situation where, and assuming they don't have very good awareness of danger, they are now getting attention because we have to chase after them, and now we're in a whole situation where we are doubly reinforcing that whole thing. It's a very hard situation to treat because treatment for one plays into the other, right? So if I try and prevent you from escaping by tracking you down, now all of a sudden you're getting reinforcement out of that too. So it very quickly becomes complicated if again, once you start viewing these things through this lens and how that should be guiding and directing our behavior, okay? Then there are these idiosyncratic ones here, keep an eye on time here, where we have these idiosyncratic things where, sometimes these behaviors come out because, they don't want their caregiver to leave. That would be a little bit more unique. Or they're particularly controlling or rigid, and so therefore doing these, or engaging in these behaviors continues to make things continue to be rigid, right? People back away from me and don't disrupt my rigid play as long as I continue to do these behaviors, right? So this is where we make this transition from how we understand behavior into what do we do with that understanding, right? So the way I talk about this is in terms of function-based treatment. How do we match our treatment to our understanding of the behavioral function? If we don't understand why kids are doing things, we might accidentally treat it in a way that is now going to make it worse rather than better, okay? So if we mismatch that function, so we make a mistake, which happens, and we don't understand the behavior in the outset right away, ineffective at best, could be countertherapeutic at worst, right? So I already kind of talked about this one, the timeout for work refusal. So like, kid has an issue, then all of a sudden work gets, they get transitioned to another place, work goes away, et cetera, right? Timeout works it is okay in a lot of situations, but we better be pretty darn sure that we understand why behaviors are happening. Otherwise, we're going to accidentally do things that are going to make it worse or feed into that behavior there, okay? So, got a couple examples here, right? And I think this will be notable as we kind of work through this. So, same situation here, right? So, parent is playing with a sibling, child screams and hits the sibling, parent scolds the child, okay? Second one, preferred toy, same behavior, child screams and hits the sibling, and the sibling drops the toy and runs away. Different one, right? Child is told to clean up. Same behavior, child screams and hits the sibling, and then the child is sent to timeout. So we have here different setting events, right? Different triggers. The same behavior, different outcomes, right? So this is where we get the benefits of putting on our detective hat and understanding behavior before we intervene, okay? So from our earlier slides, we learned that if we're creating hypotheses around why this is happening, okay, attention on this one seems like a pretty good hypothesis there. Getting something that they want in this situation seems like a pretty good driver there. And escape out of the thing they don't want to do seems like a pretty good driver there. So how do we treat these things? We aim to replace the behavior that is functioning for them, so whether it's aggressive behavior, disruptive behavior, et cetera, we aim to replace that with a more functional, more appropriate alternative, okay? So in this first situation, that is wanting, where attention is the desired outcome, rather than child screaming and hitting sibling, we would teach them to ask to play, rather than going straight to these challenging behaviors, right? If we do that, we get a different outcome, a more preferable outcome, which is now we are now playing with them rather than going into this back and forth with providing negative attention, all right? In this situation, right, again, same behavior, child screaming and hitting the sibling, but in this case, can we teach them to ask for a toy by doing practice with them in terms of being able to practice that pairing of that relationship between if you ask for something, I'm going to give it to you, right? Whatever that asking looks like, right? So if we're talking about a kid who is able to use verbal communication, great. We'll teach them how to use those words and which words to use, no problem. If we're talking about a kiddo who's using more augmentative communication, right? Okay, we've got an iPad, we've got a picture card system, we've got Any of these things that are designed to help kids bridge that communication gap. Those are the behaviors we want to be reinforcing, not the other ones that they have historically been using. Teach them to ask for the toy. Now the sibling shares the toy. That might be a little rosy. They might not share the toy. Might have to be working back and forth with us who are more willing to do that stuff. Lastly here, again, same behavior, except if we teach them to ask for a break, that is certainly a more preferable outcome, and we're willing to provide that, assuming that that is going to then allow them to take a brief break before they get back to doing the thing that they need to do, right? So, as I was saying, we replaced the behaviors that we don't like to see with behaviors that are more adaptive for them, right? You guys as parents know your kids really well. So you see these behaviors, and you know, based on the context, this is probably why this is happening, or this is what they're trying to communicate to us, right? Other people who work with your kids, they don't know that, right? And so they're sitting there in the dark trying to figure out what's going on, how can I make this better, et cetera. Well, if we can replace that with a more universal alternative, which, you know, if a kid is able to use their device or use some other behavior that is able to be more universally understood, now we're that much further down the road in terms of being able to understand and treat these things, okay? So, along with being able to teach them those things, this is kind of where the heavy lifting comes in, because invariably, when we stop reinforcing those behaviors with the preferred outcome, very, very predictably, we get this situation where we get what's called an extinction burst, which is essentially when behavior has been reinforced for quite a while, and then we stop doing that. Now we're mad, right? And now we're going to jam that much harder to try and make it work the way we understand it to work. Again, nothing nefarious there. They're just trying to maximize the way, you know, this to work as it always has, right? But when we start working on those things, essentially what we're teaching them with these outcomes is that, no, this isn't how this works anymore, and we're going to have to go and weather through some of that in order to get to that place where we are no longer viewing these behaviors as the tool or the primary tool to get these things done, right? So we are essentially rendering that problem behavior non-functional, okay, and essentially telling them through our teaching and our trials with this that this is what is your most efficient pattern now, or your most efficient way to get this, not this, okay? So, getting a little more specifically, right, and a lot of this stuff is more generic and should be tailored with work through, you know, a psychologist, behavior analyst, et cetera. But essentially, I mean, these are fairly universal tenets, right? So, like, when we think about how we treat attention, or these behaviors that are designed to get attention, we want to be setting aside time to spend with them. I mean, that's kind of like the whole principle of like pre-filling the bucket, right? If the bucket's already full, are you going to need to do things to fill that bucket? The motivation usually typically is less. So now, for some kids, this is hard because they are a bottomless bucket, and you could spend 8 straight hours with them and the bucket is not full. That makes that a much less doable or tenable recommendation or strategy. But again, that's something you figure out over time as you work with each individual kid. The power in ABA, or the power in behavioral framework or conceptual framework for this, isn't blanketly applying these principles to every kid. The power is by understanding the unique situation for your kid, and then using that technology, so to speak, to then tailor what we do and how we respond for your unique kid. Okay? So, for example, like I said, setting aside time. Maybe that works for some kids, maybe it doesn't. That's one of the things we kind of go through and think about. Teaching them an appropriate way to get your attention. So as we kind of said, what are these ways that would be a replacement for these behaviors? Practicing with wait times, okay? We need your kid to wait for 10 minutes. They can currently wait for 5 seconds. We have 2 options. Either we can start at 5 seconds and build up from there, or we can hold it at 10 minutes and watch them struggle days, weeks, years, okay? So then the last thing here is called planned ignoring, and essentially what this is when we see these behaviors that we think are designed to get attention, it's best to ignore, or what I call neutrally blocking those things. However, if a kid is doing things, this is the caveat, if a kid's doing something dangerous, we don't ignore that. Okay, that's the important caveat there. Okay, Moving through here with tangible, we want to be able to teach them appropriate ways to ask for things, right? So if you want that toy, well, then we need to ask for it, not engage in these behaviors. Again, working on things like setting timers, telling them that playtime's over, giving those redundant warnings usually allows them to transition better. Let them know exactly when and how they can have the toy back, right? If their receptive language is at the point where that's not going to be helpful, then again, for your individual situation, maybe we need to figure out alternative ways to convey availability of things, right? So like, okay, you might not understand if I'm going to tell you, hey, I'm sorry, you're not going to be able to have that right now. But can we figure out other strategies to work around that? Yes. Again, and this kind of dovetails in with that, practicing sharing, removing them when we have these behaviors. So for example, playing with a toy, engaging in self-injury, those things are incompatible. We would not want them to be able to do both of those things at the same time. Or while they are engaging with a toy, reaching out and getting aggressive with sibling. Well, probably shouldn't continue to have access to that thing if we're also engaging in those behaviors that we don't want to see. Lastly here, again, recommendations for escape. Obviously, teaching kids to ask for a break before we get to meltdown zone and before we get to total dysregulation is going to be one of our primary backstops for avoiding or keeping ourselves out of those really intensive situations. Breaking things into smaller chunks, providing more frequent breaks. Using, again, everyone's probably heard of this, but the first then format, right? So it's essentially giving them laying out what the contingency is, okay? First we got to get our work done, then we can get a break, right? And again, bridging this in terms of idiosyncratic communication needs, okay? We can certainly lay this out in terms of a visual for these kiddos to understand with enough practice, okay? We can provide rewards for completing tasks, only allowing breaks after some work has been completed, even if that's a small amount of work. If that's where you have to start, that's where you have to start to get a foothold. So generally speaking, we want to have consistency, whether that's writing down rules for everyone so that different providers, different PCAs, whoever is working with the kid, we are all operating under the same understanding of how these behaviors work and what we're doing about it. If kids view different people as being more likely to respond to their behaviors in a way that's favorable to them, pretty common to see that kids behave differently in different settings according to their understanding of whether the slot machine is going to be successful there or not. As far as and this kind of, again, the consistency dovetails in with predictability here, right? Making sure that we're telling them beforehand what is going to happen. Well, again, and telling them is sort of loose there, right? So making sure that we are saying, communicating in a way that is clear to them, that resonates with them. And then finally, and this is again kind of where the rubber meets the road, is even in challenging situations, okay, sticking to your guns, making sure that we're not giving in. There was a study that was done 5 years ago, 7 years ago, that was looking at trying to identify what is the level of adherence to treatment recommendations that we need in order to actually get good outcomes. The good news for everyone in this room is that the answer was not 100%. Okay? So we do not need to be perfect. We do not need to be 100% in step. That it gives us some wiggle room for those situations where it's either not feasible or we just have to get through this situation, whatever. The good news is it's not 90%. Good news, it's not 80%. Okay? Where things really start to fall down is when we start getting into that 60, 70% range in terms of adherence, right? So if we think about how that translates, out of 10 situations where we're having an issue, if we are pretty good at least 7 out of 10 times, we're probably going to start seeing good effects, okay? So we can use this framework to think about these other things too in terms of these other things that are common to not only kids perhaps with Wilson, but also other kids with developmental issues. Issues like sleep disruption, toileting delays, feeding difficulty, intolerance to medical procedures or equipment. Can't tell you how many kids I've worked with who we've been working through. How do we get you to wear your glasses? How do we get you to wear your hearing aids? How do we get you to take pills? How do we get you to tolerate an EKG, right? It's on and on and on. When you work with developmentally and medically complex kids, you start figuring out, I can apply this stuff to all sorts of things as a vehicle to get these things done, which are so critically important to them and their care. So again, take-home points here. Oftentimes, this challenging behavior serves as a communicative role or purpose for these kids. These common ways that these behaviors function, access to preferred attention, activities, objects, escape from things they don't want to do. Treatment typically involves identifying what that function is, okay, so that we can then match that with a treatment that will be tailored to that specific issue and that relationship for that specific kid. And then oftentimes, when we think about how we deal with this, right? So when we start seeing some of these challenges, earlier is better, and working with somebody who could help you game plan about how this stuff needs to be approached is critically important. Primarily because it is a very lonely place as a parent to have a kid who engages in these behaviors. When you go to the playground, you go to the parent conferences, you go to a friend's house, and you start talking about things like, my kid hit me in the face, right? Or my kid is 7 and isn't toilet trained, or whatever. Typically the response from the other parent who might be parenting a neurotypical child is not, oh yeah, I understand, we dealt with that too, right? So because of that, right, it's good to be working with people who understand those situations, have a lot of experience working with those kids, and can be that person to kind of help walk you through that and down that path. And that's roles like people like myself, that's people like Dr. Langenfeld, that's folks with our speech and our OT and our PT and this whole integrative approach for these kiddos, okay? So these are my references that I kind of use throughout here, and that's, as I say, is that. So I know that we've left some time, I think, for questions, maybe about 10 minutes here. If any of you guys have questions for Dr. Langenfeld or myself, be happy to take those. But otherwise, thank you guys so much for having us here and for allowing us to talk about something we're very passionate about and something that seems like daily striving to create more services for these types of kiddos. So.
Go right ahead. Okay, thank you for the conference. It was really interesting for you both. It looks like your conference was based on a day in our life, because we see many of those behaviors. So would you have a tool or something? Because one problem we have, our kid, he slaps other kids to get their attention. So that's pretty much it. And we've been working from lots of places. And one thing we have difficulty is that we feel like he does not understand time or patience. So you go pointing at a kid and then slapping the kid, like the very next second, because it's not patient. So how can you integrate some time of patience in this? Because we feel that replacing the inappropriate behavior requires you to do it now. So if before he slaps you, well, you should just give him the toy. You should go and play with him. But what if you are doing the dishes and you cannot play? You'll just slap him and slap him.
Yeah.
So would you have anything any tool or anything we could use for patience or for understanding time?
Yeah. So obviously, when it comes to time, that, for all of us, that infers that we understand the number line, that we understand numbers, math, stuff like that. When you can't make that same inference, we have to start getting creative with how we convey those things. And it took me a while to figure out, how do I convey this very relatively complex construct to a kiddo who doesn't have that baseline understanding, right? And so, first of all, trying to find visual strategies to do that. I use things like visual timers all the time, that kind of allow them to see, okay, you don't know that 5 is more than 1, but you do know that there is more of this pie left than there is, after however many seconds, right? And so they can see that, and that, you pair that practice enough times, and they start to realize, room, timer goes off, room, timer goes off, and so then through repeated practice with that, you can see the understanding that, I'm more willing to wait because I know that it's coming, right? So the other caveat to this is when we think about those situations, right? Kind of putting this or feeding this through this framework, you think about this okay, we need to understand why a kid is doing what they're doing, right? So if it is because our understanding of that directs us to how we need to be training it or practicing it outside of those sessions. If we were talking about a kid, who might be more neurotypical with anxiety, we would say the time to work on anxiety is not when you are super anxious and in that situation. We need to be working on anxiety and developing strategies and practicing those outside of the times that you are anxious so that you have access to those skills when the bullets are flying, so to speak, right? And so when we think about that in terms of these situations, our understanding of how this particular situation is functioning or how this behavior is functioning in this directs us to how we need to be practicing that, right? So for example, let's just say a kid is playing alongside another kid and ends up reaching out and hitting, whether that's impulsively or designed, like I don't have another way to communicate to you that I want your attention, right? Outside of that, then we need to be practicing, okay, this is how you get the attention, right? And I'm not going to give you that attention when you are doing this, but we are going to practice. Say, okay, we're playing together, we're having a good time, I'm giving you your preferred type of attention, whatever that looks like for your kid, right? And then I'm going to briefly withdraw, and I want you to communicate for it back. When you're first starting that, kid might look at you like, I don't know how to do this, right? But then if we practice, whether by modeling, whether by pairing again and again hand-over-hand use of certain communicative modalities, now we're all of a sudden able to start sort of some momentum in the other direction where I withdraw, kid wants me back, hits whatever they need to do to get that back, and now we're there, right? And they're getting it back immediately, maybe at first because they don't have the patience to wait for that, right? So then fast forward some days, right? We get some good practice under our belts. We're withdrawing our attention, and the kid is now hitting or communicating reliably. By hitting, I mean I'm thinking of like a device in front of them, right? But like, and now we start introducing maybe a visual timer that says you need to wait for 5 seconds for me to come back, right? And then we get them comfortable with that, and then we go to 10, 15, 20, 30, etc. All the while we're practicing that outside of those sessions, right? It's really hard when you're working with a kid's interactions with other kids because you have this other variable out there, which is the other kid, as opposed to something more controlled like us and our reactions. But we're rarely successful practicing those with that other variable in flux there, right? So like a sibling, for example, or a young sibling especially, you can't say to another 3-year-old, don't react when they hit you. It's really hard, right? So what we do is we start with us to get a foothold and gain some momentum, okay? Then we work to integrate another kid as the kid develops that framework there for how this interaction needs to work if I want this attention. And admittedly, it's sloppy at first, right? Because especially when you start to integrate, they've got this understanding of how this works here, but it maybe doesn't automatically generalize to the situation from the other kid. So then we're working in there very closely as we slowly integrate that kid into being able to do that. And it's a lot, it's more complicated than that, but like that's sort of like the general framework that I would probably start assuming like I was presented with that situation. Yeah.
I was going to ask if you could talk for a few minutes about sort of some of the like negative connotations or controversy around ABA. And when I've asked providers this, I sort of get, there's good ABA now, and ABA used to be bad ABA, right? And like, first of all, if that's true, how do I find good ABA?
Sure. Sure. So I think Dr. Langenfeld would probably say this too, although he might not want to admit it. I'm sure there's bad pediatricians out there. Everybody, what do they say? In every medical school class, somebody had to finish last, right? So you can run into bad pediatricians. You can run into bad speech-language pathologists. You can run into bad psychologists. You can run into bad contractors. It's all out there, right? Same is true for ABA, right? You can get people who aren't well-trained. You can get people who are misapplying some of these concepts or robotically applying certain concepts in order to, because that's what it said in the big white textbook that you used before you took the BCB's exam. Like I said, where the power comes is being able to use these things flexibly to understand a kid and flexibly apply these things to your situation, right?
I think that there's been a change in how ABA is delivered from like early days.
I don't.
There is a big, real
Yeah. Yeah, I don't think so broadly speaking. I think that, especially early on, you might have, so there was, where a lot of press came from this was there was a center, I think it's out east, maybe in Pennsylvania, New Jersey, somewhere in there. What's that?
Which is where I live.
Yeah, so there was a place called the Judge Ruttenberg Center, and they tended to see kids who had very, very severe intractable self-injury. These are kids who are headbanging to the point of detaching retinas, creating traumatic brain injuries, eye gouging, things like this. This is like really serious stuff, right? And so when they exhausted everything they could do to find reinforcement-based strategies, they had to start going to punishment-based strategies, which I think is where the connotation goes that like we just go straight to like we're going to punish a kid for these behaviors to try and get it to go away because by definition, if we punish something, it should be reducing it down, right? By definition. Sometimes those things get applied and they don't do that, and Anyway, so I think where the field took some flack there was when some of those situations were unsuccessful. You had maybe misapplications of punishment. Maybe some of those forms were too aversive, right? Or they just weren't done very well, right? And so almost all of my work has been in using like reinforcement-based strategies to make this happen, to shape behavior. And yeah, I'm sure some people with autism probably found it aversive to be told no, right? Or to be told, sorry, pal, you still got to finish this work. And they scream and cry and all this stuff, and it's this really, shaking situation for them. But sometimes there's no way forward besides forward, right? And so you're going to have to do this, and it's going to create some distress, and that's the way it goes. But I think that in part contributed to that feeling too. But again, like I said, this is not a field that is pinned or founded on, hey, we're going to use the most aversive strategies possible to get the quickest gains, right? I think the clinician who is soundly using this stuff, again, as we kind of talked about, in a tailored way to shape behaviors and who are willing to go through those difficult moments, I think that's where you're going to get your really good gains there.
And before, I just want to dovetail off that just to say, in situations where we do talk about, we see a lot of kids who come in with concerns for autism, so that's kind of the biggest thing that we'll see, and we'll talk about therapies, and there are some families where they're vehemently against ABA, and that is fine. That there's nothing wrong with that because they've either read about controversy or they have feelings about how we want to address behaviors, and there are other modalities that are available. But what I would always encourage parents to do is feel empowered to learn about what's out there, to talk to the people who are providing it, and the place that will do it the best will be the ones who will develop a plan collaboratively. Again, this like interdisciplinary, collaboration with different providers, but also with the families. Like the family is the one who should drive what it is that we want to do and what goals we want to accomplish. So if they're not doing that, that's problems. But if they are willing to talk to you about it and talk about, okay, what we're seeing is this is where we feel like the needs are. Does that gel with what you guys are thinking about? What are the things that we want to accomplish? That should be the place that you feel comfortable going. Okay, so please be empowered to talk about that with them. So go ahead.
So I can piggyback off of two, but ABA, we had ABA with our daughter. It took us like 3 or 4 therapists, and going above them to their manager, above them, I basically cycled them in and had a sit-down meeting with their boss, saying we can't put her in a box.
Yeah.
She's not a mold in that box. We
Absolutely.
look at the bigger picture.
Yeah.
And finally got a therapist that could work with communication, because that was our
Yeah.
thing with her. But now piggybacking on him, when you got that sibling with a neurotypical child, and you have that, so my son is 7, he gets angry, frustrated because she will come in and demolish something. So now I have this
Yeah.
screaming 7-year-old and her giggling, laughing. Who do I address and how do I address that first? Do I go, because he's not understanding the concept of that her brain works different. I don't know, and I end up then with him screaming, crying, upset, and her giggling over here thinking it's funny because everything to her is funny. Is including consequences.
Sure.
It is funny.
Yeah.
So I don't know how to balance that, and I struggle with that balance.
For sure.
This is unfair, but we're also out of time. So whatever answer you can give quickly, then we're going to.
Okay. I don't know, Adam, do you want to?
I think you might have better.
So yes, that is a really challenging situation that a lot of parents face when you have, like I said, 2 young brains that are at odds, right? I think that to answer like quickly, the answer is working with both, right? And so the times that outside of there where we are, in those when they're in close proximity and likely to have some of that overlap, that's problematic. I think working. Was it your 7-year-old who was more neurotypical, or?
He's not
Yeah. Okay. So working with your 7-year-old outside of those situations to sort of like, rather than just trying to do damage control in the moment when something is just demolished and he's having trouble with it, trying to work on those situations outside of that, but then also trying to figure out how we can maybe practice some structured play where like hey, you are working mostly with him, sort of in talking through like, hey, so being observant, like we see what your sister is doing, right? And we know that like she might try and come over here, right? So how do we deal with that? Do I come and get mom? Do I get mom to help me kind of like close things off? Do I, so there's all sorts of ways, but it's got to be with both. And of course, like, for example, like working with your 3-year-old, right? So doing, again, outside of those situations, work on like, hey, when brother gives you the nonverbal, gives you the stop, we need to work on stopping so that, which again is a big ask for a 3-year-old, but like working on that skill and recognizing that that nonverbal sign is communicating like, please don't do this, right? And you might need to do some behavioral things around that to make it worth her while to stop, like reinforcing with other things that are preferred because she stopped, right? So, but it's very challenging. You are not alone struggling with that. There's not something that's unique to you. Everybody with young kids, I have 2 young kids myself, and my almost 4-year-old and 21-month-old destroy each other's things all the time, and I find myself pulling out my hair. So,
Thank you, doctor, so much for a lot
yeah.
of great information.
Yeah, you bet.